Good morning, good afternoon, and good evening to all of you. Wherever you're joining from, we are glad that you are here. I am Caitlin Mitchell, a consultant at WHO, where I support the WHO UNFPA Learning by Sharing portal. Today, the WHO UNFPA Learning by Sharing portal is hosting its first ever webinar with a focus on strengthening adolescent responsive health systems, with examples from Chile, Moldova, and Ethiopia. Before we begin, I would like to go over some general housekeeping. First, we will be providing Spanish and French interpretation. To utilize the interpretation feature, please read and follow the instructions on the interpretation slide. We will also be recording today's webinar. You can access the recording on the WHO HRP YouTube channel. During today's webinar, you will have the opportunity to learn more about the Learning by Sharing portal, explore successful interventions in Chile, Moldova, and Ethiopia, and listen to our panelists discuss their proudest moments along with the challenges that they have experienced and recommendations for other countries. We will also be taking questions from all of you, our attendees. I would like to pass it over to Dr. Velashni Govinder, a scientist in the Department of Sexual and Reproductive Health and Research at WHO, to introduce the Learning by Sharing portal. Welcome, Velashni.
Thank you for all participants joining us from all over the world at this time to learn more about this important topic on adolescent and sexual and reproductive health. And I will just share with you very briefly about the Learning by Sharing portal, which we are very proud to collaborate with UNFPA on. The portal focuses on the integration of sexual and reproductive health within universal health coverage. Universal health coverage seeks to ensure that all people have access to quality services without suffering financial hardship. And sexual and reproductive health and rights is an integral part of UHC for reaching vulnerable and marginalized populations and is a marker of achieving gender equality. Through the LSP, we seek to share and build a repository of rich implementation stories on how we implement sexual and reproductive health through health systems interventions across different settings and covering a wide range of topics, including digital health, health financing, and reaching vulnerable and populations that are marginalized. The focus of the Learning by Sharing is on the how of advancing. And so through targeted health systems interventions that respond to real world challenges in access to sexual and reproductive health. And without further ado, I would encourage you to visit the Learning by Sharing portal. The links will be provided. And I will now hand over to my colleague, Sherry, who will share with you more on the three stories from Moldova, Ethiopia, and Chile that speak to the topic. Over to you, Sherry.
To be here today to discuss how we can strengthen adolescent responsive health systems by looking at three case studies from Moldova, Ethiopia, and Chile, all different regions, each with a unique context, to better understand the path that each country took towards making their health system more adolescent responsive. I'll get us started firstly with a brief background as to what an adolescent responsive health system is and why it is needed before diving into the case studies, which will set the stage for the panel discussion. Next slide, thank you. So what do we mean by an adolescent responsive health system? Adolescent responsive health systems refers to making existing health services responsive to the needs and preferences of adolescents by incorporating evidence-based elements throughout all components of the health system, rather than implementing isolated interventions. Essentially, this signals an evolution from traditional standalone models of adolescent-friendly services towards a systems approach, which means that policies, procedures, and programs across the entire health system are adapted to respond to the diverse needs and preferences of adolescents. Next slide, please. I would also like to talk about why an adolescent responsive health system is needed and why we're calling for this. Essentially, it is because although the health of adolescents has improved, over the last 10 to 15 years in some areas, it has remained unchanged and unfortunately worsened in other areas. As we know, a number of stakeholders have a role to play when it comes to advancing adolescent health, including adolescents themselves, as well as parents, teachers, and the wider community. Health workers clearly also have a role to play. As the first bullet point here speaks to, adolescents still face many barriers in obtaining the health services they need and indeed have a right to. Efforts to make health services adolescent friendly have led to some benefits, such as improving access to contraception, and for some groups, for instance, married adolescents, but there are still many barriers that need to be addressed. The second point that I would like to reiterate here is that an adolescent responsive health systems approach marks a shift from the siloed approaches towards integration across the entire health system. So highlighting lessons from countries who have made promising strides, such as we will do today, is important because, as we know, many countries have adolescent-friendly health service standards in place, but they may not be applying them systematically. Similarly, a small but growing number of countries are integrating adolescent-friendly health service elements into their national health systems. It is essential that we draw lessons from these examples and share them widely so that other countries can learn from their experiences. So without further ado, let's take a look at the 3 countries. Next slide, please. Let's begin with Moldova. In terms of the broader context, to mitigate the effects of instability and disruptions to health systems in the 1990s, the government opted to focus on reorienting the public health system, including prioritizing adolescent sexual and reproductive health needs through policy and legal reform. The key interventions in Moldova included youth-friendly health services, which were implemented with specific actions across each of the health system's building blocks. As the second bullet mentions, this was done across 41 youth clinics. Additionally, the government provided free services for adolescents through the National Health Insurance Scheme. Finally, a data-driven health systems approach was implemented, incorporating adolescent-specific training for healthcare providers. Now, these interventions resulted in a number of positive outcomes. Firstly, access to youth-friendly health services for 10 to 24-year-olds increased from 5% in 2011 to 38% in 2023. Secondly, and looking at the table on this slide, you can see that contraceptive pill use among sexually active adolescents also improved from 6% in 2014 to 13% in 2022. Additionally, the majority of sexually active adolescents, 74% in fact, continued to use condoms. Thirdly, and notably, Moldova saw its adolescent fertility rate decline among those aged 15 to 19, from 34 per 1,000 young women in 2015 to 23 per 1,000 in 2022. And finally, abortion rates among adolescents dropped by over half, from 11.7 per 1,000 to 5.9 per 1,000 in the same time period. Moldova's experience underscores the importance of strong leadership and governance in reorienting the public health system, coupled with efforts to address financial barriers and a move towards data-informed services. Taken together, these efforts led to positive, measurable changes in adolescent sexual and reproductive health. Next slide, please. Now, let's turn to Ethiopia and the efforts made there to galvanize support for adolescent sexual and reproductive health. In terms of the broader context, adolescent sexual and reproductive health received increased focus in the country over 2 decades through targeted policy and legal reforms, which specifically aimed to increase access to contraceptives and prevent child marriage. The key interventions in Ethiopia consisted of, firstly, addressing the financial barriers adolescents faced in accessing contraception by ensuring free access, while in parallel, strengthening the procurement supply chain and distribution systems, as well as health management information systems to track disparities. Secondly, there was a strong focus on health workforce development. This was done through the rollout of training materials, including in-service training for health workers, with the integration of adolescent health, including sexual and reproductive health, into pre-service curricula of nursing and midwifery training institutions. There were several positive outcomes as a result of these efforts. Firstly, there was a reduced unmet need for contraception among adolescents. Secondly, modern contraceptive use among married adolescents increased. And thirdly, there was a notable decline in repeat pregnancies. Finally, there was also a marked decline in the equity gap in modern contraceptive use among married adolescent girls, all major achievements. Ethiopia's model highlights the power of strong policy support, complemented by in-service training to improve adolescent sexual and reproductive health outcomes. I'd like to turn our attention now to the impressive model that Chile adopted. Next slide, please. In the case of Chile, adolescent health reforms began in earnest in 1995, which helped to firmly establish adolescent sexual and reproductive health as a national priority, which resulted in a range of legal and policy reforms to increase access to services for adolescents, particularly contraceptives. The package of interventions centered on strong leadership and governance and adolescent-friendly laws and policies to make sexual and reproductive health services accessible. Secondly, ensuring sufficient budget allocations for scale-up of adolescent-friendly health spaces, including training and staff professional development. Thirdly, in relation to financial barriers, a universal health insurance program was implemented to enable children and adolescents to access services in both private and public health facilities. Additionally, there was a clear emphasis on accountability by meaningfully engaging young people throughout the entire policy and program cycle. Finally, steps were taken to ensure and strengthen the information system, including timely use of disaggregated data, for instance, age, sex, ethnicity, and marriage. This comprehensive evidence-based package yielded a number of positive outcomes. The proportion of births to adolescents was reduced. As you can see in the graph, the fertility rate among adolescents aged 15 to 19 was halved from 1994 to 2020. And finally, there was a significant increase in contraceptive use at sexual debut. Chile's case underscores the importance of stable leadership, financial investment, and active engagement of adolescents, alongside efforts to strengthen health information systems to guide decision-making. Chile constitutes an impressive example of what can be achieved through sustained efforts. Next slide, please. I'll leave you now with 6 key lessons learned based on the insights from the 3 case studies as a springboard to the panel discussion. Firstly, enabling laws, policies, and guidelines build provider confidence and improve adolescent access to sexual and reproductive health services. We saw this as a key element across all the case studies. Secondly, integrating adolescent sexual and reproductive health into existing health infrastructure is indeed cost-effective and improves access without creating parallel systems. My third point relates to data-driven decisions. Disaggregated adolescent-specific data in health information management systems enables countries to monitor adolescent health effectively and to make targeted improvements. My fourth point relates to the workforce. Building a competent and empathetic workforce ensures high-quality adolescent-friendly services are widely available, making in-service training a crucial element. Additionally, adolescent involvement is an essential ingredient. Involving adolescents in service design and evaluation boosts acceptability and service utilization. Finally, as evidenced by the 3 case studies, sustained efforts and investment across all these areas can contribute to achieving universal health coverage and result in improved sexual and reproductive health outcomes for adolescents. I'm very grateful for this opportunity to share a brief overview of the case studies, which taken together highlight what is possible to achieve when countries deliberately invest in strengthening their health system to make it more adolescent responsive. I'll hand it back to you now, Caitlin. Thank you so much.
Wow. And thank you so much, Sherry, for such an inspiring presentation on strengthening adolescent responsive health systems. It's great to hear real world examples from these 3 countries that are integrating adolescent friendly health services into their national health systems. Next, I would like to introduce Dr. Chandra Mule, who will moderate our panel discussion. Chandra retired from WHO last year after dedicating 30 years to advancing adolescent health. He continues to be a tireless advocate for adolescent sexual and reproductive health in his retirement. Welcome, Chandra.
Thank you, Caitlin, and hi, everyone. Botha, could you please remove this slide so that we can see the people on the screen? As we start this section, I just want to reinforce a point that Sherry made. Making health services friendly for adolescents is not new. This year, the world commemorates the 30th anniversary of the International Conference on Population and Development. There's 30 years and more of experience in doing this. What is new is that in every element of the health system's building blocks, leadership and governance, service delivery, financing, health information, health workforce, a competent and an empathetic health workforce, and medicines and commodities, actions have been taken to make them adolescent responsive. And in addition, a new block called partnerships has been developed to make adolescent responsive partnerships. And the last point is that this has been done across the country and over time. So, what is new is that it has been done in a systematic manner and done over time. And you see the results. What we're going to now hear is some points from each of the three countries to kind of build on the short presentation that Sherry made. And just to remind you that the case studies have been published, and Caitlin will tell you how to access them. Let me start with Chile. Matilde Madaleno is a good friend. She had in earlier years had a long and successful career as the regional advisor for adolescent health in the Pan American Health Organization, which is WHO's regional office for the Americas. She's now head of public health in the Faculty of Medical Sciences in the University of Santiago in Chile. So, Matty, your case study has been published, and thank you for leading that. Sherry has presented brief highlights. Like I said, you worked in all the building blocks. But if there's one thing that you're really proud about your case study, what would that be? Feel free to speak in English or in Spanish.
Buenos días, muchas gracias, Chandra. Bueno, nosotros en Chile nos sentimos muy orgullosos de los logros alcanzados en salud adolescente, fundamentalmente gracias al liderazgo y la gobernanza sólida que existe a nivel nacional y a nivel local. El Ministerio de Salud ha jugado un rol clave en el avance de la agenda de salud adolescente, logrando que se formulen leyes, estrategias, intervenciones que guían y sustentan la acción, pero además desarrollando normas, estándares que permiten, ¿no es cierto?, definir el camino a seguir e implementando mecanismos administrativos y financieros que permitan entonces transformar las intenciones en acciones concretas. Ahora, este liderazgo en Chile ha sido clave para asegurar la sustentabilidad y la permanencia de los programas a lo largo del tiempo, permitiéndonos entonces avanzar más allá de los cambios políticos y más allá de los gobiernos de turno. Podemos decir con orgullo que Chile tiene 3 décadas de programas de adolescentes desde el año 95. De hecho, tempranamente, ¿no es cierto?, se implementó en los objetivos sanitarios del sistema una meta de reducir un 30% el embarazo adolescente que se logró. Yo creo que los avances legales que este liderazgo y esta gobernanza han producido son muy importantes. De hecho, en Chile, hoy los adolescentes pueden tener acceso y tienen derecho a elegir su método anticonceptivo y tienen acceso a la contracepción de emergencia. Entonces, las políticas nacionales permitieron sustentar los servicios de salud adolescente, ¿no es cierto?, innovando con prestaciones de servicios como los espacios amigables de 19 años. Por lo tanto, yo creo que es importante reconocer esta disposición y esta apertura de los líderes políticos, pero también de los funcionarios gubernamentales que han hecho posible estos avances. Yo creo que la preparación y la capacidad de ellos, ¿no es cierto?, han consolidado los avances, pero además también los han transformado en los campeones de salud adolescente de este país.
Thank you, Matty. So we all take away the messages that we that register when someone speaks. The message I take away from what Matty said is that the critical point in Chile was leadership at the national level and at the local level and all the levels in between, and that it was sustained through changes in government and over time. And all the changes that have resulted finally make sense because it translates into realities for the lives of adolescents. Simply putting policies in place is of no value in itself. Thank you, Matty. That was very useful. I'm going to come back to you, but now I want to move to Ethiopia. Redit Negusi is a medical doctor and a passionate advocate for adolescent and youth sexual and reproductive health, gender equality, and meaningful and inclusive adolescent and youth participation. She works with local organizations as well as international ones. Redit, as a young professional, could you speak to one issue that you're really proud about? You and the co-authors of this brief are really proud about with the Ethiopia case study. Over to you, Redit.
Thank you very much, Chandra. Hi, all. It's a pleasure to share our experience from here in Ethiopia. So one of the work done by the government is making contraceptive freely available in government health facilities through health extension workers. So health extension workers, to give a brief description on health extension workers, they're government paid healthcare providers who take training for about a year to provide basic health education, information, and services in rural and hard-to-reach communities. They work on immunization, family planning, maternal health services, and such. So one work done by the government is to respond to the financial barriers to access family planning, making them free of charge. And the second thing is national level scaling, which is expanding programs to reach more adolescent and youth nationwide. I can give one example on that. That is Smart Start. It was a 4-year project. It was designed to help young married adults and girls, which were aged from 15 to 19. And they wanted them to focus on what's relevant to them, including financial stability, ability to set up to new homes, healthy children, and such. So it was a youth empowerment project, and they worked on demand creation. That's currently scaled up to nationwide level by the Minister of Health in Ethiopia. Thank you very much, Chandra.
Thank you, Regit. In Ethiopia, just like in Chile, they worked across all the 8 building blocks, as you will see in the brief. And one of the issues that we hear Reddit speak about is this huge number of health extension workers, 35,000 health extension workers and more, who, in addition to meeting the needs of adults, also worked to create public support and to provide contraceptives in the community, in addition to the health facilities. And what is fascinating is they took an empowerment project and then expanded it because it had been demonstrated to be effective. So many useful lessons to take from Ethiopia. One of the things Reddit said was she's a passionate advocate for meaningful adolescent and youth participation. And the next speaker, Valerie Babenko, is 15 years old. She's a 9th grade student at the George Calinescu Theoretical High School in Chisinau, Moldova. She volunteers with Neovita. You're going to listen to Galina Lesko later. Galina is one of my great heroes, one of the champions of adolescent health globally. But what we'll now have is Valeria speak about. Valeria is a volunteer, as an advocate, as a peer educator, as a researcher. So Valeria, what is the one message that you and Galina are really proud about, and jump up and down and you can say with celebration that this is really something that we are proud of? Over to you.
Hi, everyone. Thanks for the question. I'm so proud to share my experience with you. Well, I'm proud to be a volunteer at Youth Clinic Services because it offers many opportunities, such as learning more about my mental and my physical health. With the knowledge, I can also inform others with the things I knew. I would like as many as people possible to know about Youth Clinic, especially those who need help and who don't know where to turn. When I was going through a difficult time, Youth Clinic Services helped me with the support and care that I needed. And I'm incredibly grateful to Youth Clinic and proud to be a volunteer and a part of that big organization and family. Thank you so much.
Thank you, Valeria. So wonderful to hear you speak about how this program benefited you and how you could use this learning and the empowerment to benefit others.
Yes.
Wonderful to see so many people in this webinar. And one of the persons in this webinar I'd like to call out to is Gwyn Hainsworth, who contributed to the development of a brief that we put together on adolescent-responsive contraceptive services. Thank you, Gwyn, and thank you for being here, and thank you for all the work you've done in this area. I'm going to come
Thanks
back
for
to you,
having me.
Matty. I'm going to come back to you, Matty, with a question on, there are a number of people in the audience, and, there are people who are probably thinking about what they could do differently or what they could do more. What would be one do or one don't that you would advise decision makers in countries and those who support them? So one do or don't, and why? Why would you say that one do or don't? Over to you, Matty. Did you hear me, Matty? Caitlin, could you hear me?
Maddie, I believe you're on mute.
Ahora sí, ahora
Thank
sí.
you.
Perdón, pero estaba en el canal en español. Chandra, bueno, ¿qué no recomendaríamos? Bueno, yo creo que lo más importante, ¿no es cierto?, es no desarrollar programas o servicios desvinculados de los sistemas de salud. Yo creo que es el eje, y ya, ¿no es cierto?, lo dijo Terry, un error común, ¿no es cierto?, que los servicios que no están integrados en los sistemas nacionales, ¿no es cierto?, limitan su alcance y limitan la sustentabilidad. Yo creo que es crucial que cada una de las intervenciones que planeemos estén alineadas con los pilares de gobernanza, con los pilares de provisión de servicios, con los pilares de sistema, y además, ¿no es cierto?, es clave toda la intersectorialidad y la participación social y juvenil. Ahora, nosotros pensamos que esta integración en los sistemas de salud tiene que ser planificada, pensada y coordinada, ¿no es cierto?, garantizando entonces que formen parte de los sistemas. Y en esta planificación yo creo que es muy importante no iniciar los procesos desde cero, no iniciar desde tabla rasa. Yo creo que deben considerar las lecciones aprendidas del país, de los países vecinos, de otras regiones, de las instituciones regionales y de las instituciones globales y multilaterales como la OMS y el UNFPA, ¿no es cierto? Yo creo que el ejemplo de Chile, que tiene desarrollo espacios amigables o servicios de salud adolescente, que están basados en documentos normativos de Chile, pero estos documentos además incluyen las prácticas globales que están éticamente aprobadas y incluyen la evidencia, así que la integración es clave, y en esta integración no olvidar, ¿no es cierto?, la importancia de la cobertura de salud con un seguro de salud adecuado para adolescentes y jóvenes. Nosotros sabemos que ya cuando llega el adolescente y juventud no tienen seguro de salud, ya sea porque no tienen acceso a sus padres o porque trabajan y no tienen acceso. Por lo tanto, ¿no es cierto?, considerar estos aspectos me parece clave. Entonces, para evitar estos errores, yo creo que las tres palabras son enfocarse en la integración, en el aprendizaje colaborativo y en la equidad de acceso fundamental.
Thank you, Matty. Again, very useful advice. There's clearly, there was a time and a space for small projects and for learning. There's always important learning to be done at small scale. But if we want to really reach all the young people in the country with a package of services, we need to integrate, we need to use existing systems. And of course, that is not easy. It takes time, effort, planning, resources. And that's why you need frameworks like the health systems building blocks. But clearly, the message from Matty is don't do parallel projects. They are difficult to sustain and they cost an enormous amount of money. Over to you, Reddy. What is the one do or one don't that the Ethiopia team would advise other countries moving in this area?
Thank you again, Chandra. So I would also like to share with what Matthew has shared earlier, especially on health insurance. So we do have community-based health insurance here in Ethiopia too. So while they're effective in providing the financial risk protection, they often exclude a critical demographic age, especially the young adults aged from 19 to 24. This exclusion can have significant consequences as this age group face a unique health change, including mental health problems, substance abuse, and sexual and reproductive health related challenges. So this is one don't that I would like to share from my country that can be a takeaway and a lesson to others. Thank you very much.
Thank you, Reddit. I'm going to introduce Galina now. Galina is an obstetrician gynecologist. She's the head of the National Resource Center on Youth-Friendly Health Services, Neovita, in Moldova. She set up the first youth-friendly clinics in Moldova over 20 years ago and now coordinates a national network. She has a huge influence in this field in Europe and globally. So, Galina, I know that working to try to influence Moldova's insurance system was one of the things that you put in a lot of effort in. Could you share one do, one don't for countries in Central and Eastern Europe and globally, Galina? Over to you.
Thank you very much, Chandra. And using this opportunity, I want to express our gratitude to you personally and to WHO for huge support that offered us technically through this decade, because based on these evidences, best evidences, we succeed. But if to refer to your question, I am fully in line with Matilda say and Redit say, but I want to say one word: don't stop. Because integration process in the system, all this action, this is its process. It's not one action, not one great pilot of beautiful result, or one great training, or one great policy, or one great mechanism of financing. It's all together. It's long-term, time-consuming, not easy process. Periodically can be very difficult. Periodically can face many political, social, humanitarian, and etc. challenge. And context, problem, needs are changing during the time of adolescent in society, and it's a process that should be continuously adapted to our very changeable reality. Therefore, it's don't stop, even it's very difficult, even no money, if no support in one moment will be appear, and just keep in mind that this is very important for adolescent and for our nearest future. This is don't. And about one lesson about do, because I am a doctor, and for me it's much more important to do some medical procedure in very correct way. And one of very important lesson was advocacy, and offer enough time for advocacy, and in permanent where you have a possibility advocate with different actors at the different level, because it's need to have cooperation. It's not to make changes by alone. It's need to have partnership. It's need to have support, and for this it's need to do a lot of advocacy work, and this is important. This is if to say shortly. Thank you very much for this opportunity.
Thank you, Galina. Thank you. And, we're going to come back to the country teams if there are questions from the floor. But, Galina is in Moldova facing a huge refugee influx from Ukraine, so there are challenges, huge challenges. And I think Galina's one message is battle on. This is not something that you do and put a tick in your box and move on to other things. It's an ongoing issue. Let me now move to you, Jose Roberto. This is the portal is a WHO UNFPA portal. This is something that we do in strong partnership. I'm going to have a word from Jose Roberto and then after that from Rajesh Khanna. So Jose Roberto is the global lead on adolescent girls in UNFPA's headquarters, Gender, Human Rights and Inclusion branch. One of his key areas of work is with the UNICEF UNFPA global program to accelerate an end to child marriage. Jose Roberto, my friend, I have two questions for you. What is the place of adolescent responsive health systems in UNFPA's agenda? And within UNFPA's big work to strengthen health systems and achieve universal health coverage. And then the second point is, given your huge amount of focus and work on child marriage, what's the place of an adolescent responsive health system in the global program of child marriage work? Is there a health service component in that, and what is the place of an adolescent responsive system? So thank you. Over to you, Jose Roberto.
Thank you, Chandra, and thank you, colleagues. I'm glad to be here as part of the Learning by Sharing portal and this initiative, and also listening to the country case studies, profiles, and all the evidence and experience that you are bringing today to this conversation. I think it's quite important for everyone. For UNFPA, adolescent sexual and reproductive health and rights, especially the adolescent responsive services, are not only core to our mandate, core to our current strategic plan, core to our indicators, but is one of the main pillars of our global strategy for adolescents and youth, my body, my life, my world. Actually, all our narrative is about how young people can really make informed, healthy choices over their bodies, their life, and participate in the world they live in. And as you can see, the first pillar is all about access to integrated sexual and reproductive health services. And that comes with both the services as such, but we know that this conversation is moving us beyond simply the services to a more systems approach that can really tap into the scaling up, the policies, the investments, the public financing, the budget. And this is extremely connected with what we do, for example, together with UNICEF under the Global Program to End Child Marriage. Because the three main sectors that we have prioritized based on the evidence is the health systems, the education systems because of the evidence, and also the protection, including child protection and social protection. And when it comes to addressing the specific needs of the most marginalized adolescent girls, the health system has an extreme and huge role to play. Because, for example, the data is showing that 54 countries are showing that, for example, how child marriage and adolescent pregnancy is absolutely intertwined. And we need to tackle, and in phase one, for example, of the global program, we started with all of this prioritization of the adolescent-friendly youth services. In the second phase and in the third phase, we went more to this approach we are discussing here today about the systems. Because we know that, yes, you can have targeted interventions for certain populations, certain needs, equity measures. But if you really need to move the needle in a more transformative way, you need to go to scale. And that comes also with something that I would like just to bring for our attention globally, that both the evaluation of the Global Program to End Child Marriage and the global evaluation of adolescents and youth, both are calling us to also look in tandem with the scaling up to the equity measures, because we are still facing the challenge of reaching the most marginalized. And for that, all the connection to the communities, the case of Ethiopia with the health extension, I think is a way to go. We also have the experience of Mozambique, for example, linking the safe spaces for adolescent girls with the systems. And probably is the health system the more accessible. And we have seen also that for humanitarian settings. When you have the only place where adolescents can have a space, not only for the health treatment or counseling is the health system and the services. Let me stop there and over back to you, Chandra.
Thank you, Jose Roberto, for that beautiful comment. I think, one of the points Galina made is that this is an ongoing battle. It can be there can be challenges, but you have to work. One of the points Reddit made was that Ethiopia took the Sure Start program, which was a project, and found that it was working well in getting young couples to think about financial planning and placing contraception in the context of a life plan, and then is working to scale that up. And like you said, if we want to reach and connect the community-based education and empowerment activities with health systems, you need systems. Although these interconnections are difficult, but they're desperately needed. Thank you, Jose Roberto. I'll come back to you. Rajesh Khanna. So we had case studies from Ethiopia, Africa, Moldova, Central and Eastern Europe, Chile, Latin America. We don't have a case study yet from India, but we have a wonderful experience from India to share, from Southeast Asia to share. So Rajesh Khanna is the regional advisor for newborn, child and adolescent health in WHO Southeast Asia Regional Office, CIRO. Rajesh, in the first week of October, WHO CIRO organized in New Delhi a ministerial roundtable on adolescent-responsive health systems as a means to achieving universal health coverage. So I have three related questions. Could you quickly tell us what's really a ministerial roundtable? Why did CIRO decide to table adolescent-responsive health systems in the ministerial roundtable? I'm thrilled that they did, but can you tell us what kind of machinations needed to be done to make sure that they took it on? And what was achieved? Is this just another piece of paper with the nice signatures of the ministers? Is it really going to make any difference? Over to you, Rajesh.
Yeah, thank you so much, Dr. Chandra. And first of all, I would like to congratulate, the three countries for presenting such fantastic examples. And we do hope that in the region, we can follow these examples of how do we integrate the components of adolescent-friendly health services into each components of the health systems. Now, coming to your first question, Dr. Chanda, what is a ministerial roundtable? Now, in the regional offices of WHO, we have regional committee meetings, which are held annually. Now, this acts as a governing body for the WHO regional offices. They meet every year. They take certain decisions which are related to administrative, finances, financial, and programmatic. And the resolutions and the decisions that these regional committee make, they help guide the work of the regional offices and the country offices. Now, coming to the technical work, there are usually two types of agendas. One is a simple technical agenda, which can be adopted as a resolution. And then the agenda, which is accorded the highest priority, goes through a ministerial roundtable meeting. Specifically for ministerial roundtable, whereas the other regional committee meetings are open for all the participants, it is a selected group of ministers, all the ministers from the member states, and then their selected high-level government appointees who come. The topic for it has to be decided and agreed beforehand, and that usually results in a high-level political commitment, and we have a declaration which is signed by all the health ministers. Now, coming to your second question, why did CRO decide to adopt this agenda of adolescent responsive health systems? I will try to divide my response into two parts. One is the changing pattern of burden and mortality and morbidity. The second is your regional progress and the challenges that were facing the region. Now, the Southeast Asia region is the smallest region of all the WHO regions, made of just 11 countries, but strategically very important because it accounts for 1/4 of the global population in the world. In terms of adolescents, it's accounting for 27% of the world's total adolescent population, which is the highest for any WHO region. Morbidity and mortality, variable pace we are seeing. In terms of mortality, significant progress, mortality rates more than halved. But in terms of morbidity, we are seeing a changing pattern. As in other regions, you are seeing increase in mental health conditions, NCDs, violence, substance abuse. Adolescent pregnancy, because it's a platform, we have seen significant reduction from 6 million pregnancies every year to 2 million pregnancies, adolescent pregnancies, but still a huge burden. Over the last 10 years, the region has taken significant political, technical, and programmatic advances, now, which has resulted in all the countries in the region adopting favorable policies, programs. However, despite that, and as Sherry shared in her presentation, adolescents still face multiple barriers, whether related to access of care or to information. And when they do access care, they often experience more stigma, disrespect, and poor quality of care compared to adults. Now, interestingly, what we found is that the health systems in the region, they have not achieved the same level of adolescent centricity, and that is because they had been designed primarily for either the specific age groups, that includes mothers, children's, or adults, or for the management of specific diseases and conditions. Again, as you rightly said that Sherry, and you have said that the countries have moved ahead with institutionalizing adolescent-friendly health services, but the approach was quite focused. It was limited. It was focused more on curative services, making individual health facilities adolescent-friendly, rather than integrating all the components of adolescent-friendly elements into the systems. Now, the question, one important thing which came up was the countries were asking, why do we need this? We are already doing this. So we created a tool and we sent it to the countries of whether, and asked the ministries and all the partners to fill up this tool at the country level. Are you integrating the components of adolescent friendly health service components into all the health system building blocks? And it gave us the answer that there were huge gaps in it.
Sorry, Rajesh,
That
I'm
brought
pushing you a little to
yeah,
come to the ministerial roundtable and next steps.
yeah, okay. Sorry. So that led us to adopt this agenda as the agenda for the ministerial roundtable. This resulted in all the ministries, all the ministers agreeing to adopt this resolution, and we had a political and a declaration signed by all the ministers. Important thing is that this is making both the country offices accountable, the ministers, the governments accountable, and also WHO accountable to facilitate this. As a result of this declaration, we are supposed to report back to the regional committee every 2 years for the next 5 years. So in a way, we have now made a progress in at least bringing it to the highest political agenda with commitment of investments, commitment of improving the health systems and using the PHC oriented approach so that we can achieve the agenda for universal health coverage for all the adolescents. Thank you.
Thank you, Rajesh. So placing this at the highest level of WHO means that it is visible, and the fact that you have to report back on progress every year means that you have a handle to ask countries in terms of what progress has been made. And so even there's some level of accountability in moving forward. I'm going to hand back to Caitlin in a minute. One of the questions that has come from the floor is, following this progress, what would you see is a major gap that still needs to be filled? That's a question that one of the panelists could answer. For me, there have been achievements in all these three countries, but it isn't as if the job is done. I think, like Galina said, like Matilde said, there's still an enormous amount to be done in contraception, in maternal health, and there are so many other issues. I think we say achievement, but we say achievement with a small a and with humility. because there's still an enormous amount of work that needs to be done. I'm going to pass on the baton to you, Veloshni. I'm grateful to you for giving adolescents a big space in the portal and for hosting these case studies and others. I'm going to pass on the word to you to say what messages you take away from these presentations, and then from you back to Caitlin.
No, thank you. Thank you, Chandra, and thank you to the panelists just for the extremely thoughtful responses and I think important reflections. And I think just a couple of thoughts from my side. One, I'll bring it back to universal health coverage in the context of universal health coverage. And we have three important measures, if you like, of universal health coverage. It's populations that have been covered, groups that have access to services, the range of services that are covered, as well as levels of financial protection. And as we've heard from the panelists, they've been important. One of the important steps that needs to be taken is in ensuring financial protection, removing the financial barriers. But again, importantly, it's not sufficient to remove the financial barriers and say that services are free for adolescents. Are we committed and are we committing resources to expanding services, improving quality of care? So on the one side, we need to ensure that for adolescents and other groups, services are accessible and there are no financial barriers. But on the other end, in terms of the health system, we need to ensure that we're investing in a health system that is able to provide quality services. The second element I think that is important, again, is participation. I think Chandra's mentioned collaboration, engagement. I think Matilda's also mentioned the importance of collaboration. I would also point to the importance again. This year, WHO, the World Health Assembly, has passed a resolution on social participation. This includes adolescents. This includes those who are in situations of vulnerability. This includes migrants. And we know adolescents are not one group. They cross-cut with groups in terms of race, in terms of marginalization, in terms of class, caste, language, ethnicity, migrant status, disabilities. So I think it's important for us to kind of consider the wider context and ensure how do we include adolescents, not only in terms of monitoring quality of care, but also in terms of how do we prioritize services, which are going to be included, for instance, in a topic that I'm very closely engaged in the health benefit package. What services is the country committing to provide? And also provide some level of financial protection. But when we're making those decisions, are the youth, are adolescents also involved? In the interest of time, I'll hand over back to you, Chandra, and to Caitlin. Thank you.
I think back to Caitlin to make the best use of the limited time we have to address some questions. And I can see there are hands up from the panelists. Over to you, Caitlin. Thank you.
Sure, thank you. And huge thanks to you, Chandra, and to all of our panelists. What a treat to hear about everyone's proudest moments, as well as your advice for other countries. And also great to hear more about what WHO and UNFPA are doing to ensure that health systems are adolescent responsive. We will go ahead and take some questions from our attendees, and I see that we have a few in our Q&A box. So let's see, we can go ahead and begin with, how can countries assess periodically the effectiveness of their health systems and being responsive to adolescent needs? And what indicators or benchmarks should be used to measure accessibility, quality, and inclusivity in adolescent health services?
Rajesh, do you want to kick the ball quickly with your comment
Yes.
on the regional assessment, and then maybe we can have the other countries? Very quickly,
thank you.
Rajesh.
Yeah. So what we did was that we created a tool where all the system blocks, health system blocks, we created questions for each of them, making sure that certain elements of adolescent responsive elements were brought into this. Like for leadership and governance, was there informed consent? Was there, the comprehensive service package, adolescent involvement? So from leadership and governance only, there were 6 to 7 elements which were brought, and we scored them accordingly to whether they were accepted in totality or they were partially implemented. So it was not actually looking into the implementation, but it was looking into the readiness of the health system to adopt these adolescent friendly components. And this tool was found to be very useful by the countries to identify their gaps. Thank you.
Thank you, Rajesh. And Galina, did you want to answer as well? I see your hand.
Yeah, thank you. I want to answer also on question on standard and as issue, but I want to add to this how to assess effectiveness and responsivity. First, start in our country, at least from quality standard, what was elaborated with support of WHO headquarter, based on characteristic of services of quality, characteristic of health services for adolescents, and each standard have a set of indicator, and this indicator we have tool for external assessment periodically of quality and all these characteristics, and also we have a tool for self-assessment what our youth clinic are doing each year, and it's complex indicator, it's a score, and based on resources and quality standards, and this help us to improve and to analyze in quality as an ongoing process. Also we have some statistical indicator like number of beneficiary related to number of young people and etc. This is about how we measure. Was a question on measure gap. I will say for Moldova especially, it's access for some vulnerable group, including from rural area. It's not so easy. We develop because we are in a difficult social and humanitarian situation as many country, and we developed mobile and remote services like phone line and etc. But this is need to do more, and for other group, for vulnerable group, it's an open question, and I fully agree with financial sustainability. We have mechanism, we had studies, but this is remain, especially in such poor country like our country, it's a real problem. Thank you very much.
Yes, thank you, Galina, for sharing your experience. I see Matilda, you have your hand raised as well.
Sí, yo quería agregar, ¿cierto? Que en Chile nosotros usamos las guías y normas de evaluación de calidad de servicios para adolescentes que tiene ya disponible el Fondo Población y la Organización Mundial de la Salud. Y eso, ¿no es cierto?, evalúa calidad con varios indicadores que permiten monitorear y además evaluar. Pero volviendo a la pregunta de Chandra, ¿dónde está la brecha? Yo creo que la brecha está en las inequidades, ¿no es cierto? Nosotros necesitamos trabajar y llegar a todos los adolescentes rurales, migrantes, que están viviendo en situación de vulnerabilidad para poder realmente mejorar los indicadores en el futuro.
Thank you, Matilda. And I see Redia that you'd like to contribute as well.
Yeah, I wanted to share our data-driven approach here in Ethiopia too. So there is a national age disaggregated data collection and registration system to inform an evidence-based intervention. We also have a minimum service package that's placed for youth-friendly health services. And those are with set of indicators, and they're used as an effort to identify patterns and problems to the lowest level of health system. And these packages are also for workplace and IDPs or for those displaced. So we use data-driven approach. So we collect data. That's how we do it here in Ethiopia. Thank you.
Thank you, Redia. And we do have 2 more questions. I realize that we're up on time. If everyone would like to hang around for a few more moments, we could take those questions. Okay, our next question is, hello, thank you very much for this presentation. I recently graduated with a master's degree in reproductive biology from the Université Paris-Saclay. I apologize for my mispronunciation. And I hold a master's degree in bioethics. I am very interested in the work being done at UNFPA WHO. I wanted to know if someone would be open to having a meeting with me to discuss next steps for potentially joining. So yes, feel free to reach out after the webinar with any professional questions. And let me see if we have any other questions pertaining to the webinar.
Caitlin, there's a question from Jose Roberto, which I think is a very important one, and maybe it'll be good to get the panelists to say one quick word in conclusion on that particular issue. A challenge we are facing across countries is the gender and age biases of health providers. To improve the quality, we need to work on performance rather than simply on training. So it'll be wonderful to see what colleagues say. Matt, Galina, do you want to start? I see you nodding.
I look for question on gender inequity. This is a real challenge for us because almost of our health workers are women, and to keep boys in our reaching services, and we have near the 40% of our beneficiary are boys. This is a real challenge, but we try to adapt and to look on need on girls and boys and transgender people, and not linked always. But in training also, it's very important for this. When we train our staff, it's very important to clarify for them their own attitude to sexuality, to this gender issue. And after very good clarification and training, it doesn't matter very much gender of staff. Of course, it's better when we have mixed stuff, but we are realistic and solve the issues by good training to assure equitable access.
Thank you so much, Galina. So unfortunately, we are out of time. I hope that you all enjoyed this discussion as much as we did. I would like to again thank each of our presenters and panelists for all of your meaningful contributions today. I would also like to thank you, our attendees, for taking time out of your busy schedules to join us. What a privilege it has been to learn about strengthening adolescent-responsive health systems. And again, if you are interested in additional examples of best practice interventions, please visit the Learning by Sharing portal. Thank you, everyone.
Thank you too.
Bye-bye.
Thank you.
Thank you too.
Thank
Bye.
you,
Goodbye.
everyone.
Thank
Bye-bye.
you,
All the
everyone.
best.
Thank you.